We'll move on to the next speaker for this session. The next speaker for this session is Dr. Kushal Kalvit. Currently, he's working as a consultant in Medanta Hospital in Indore. Previously, he was a senior clinical fellow of critical care medicine at the Guy's and Thomas Hospital in London, where he did a fellowship in critical care. And prior to that, he also worked for a brief period as an assistant professor in the Department of Critical Care and Anesthesia in Tata Memorial Hospital in Mumbai. Dr. Kushal today is going to talk about the role of fluids and albumin in liver disease. Over to you, Dr. Kushal.
Thank you. Thank you so much, Dr. Kundu. So I'll just share my screen.
Yes.
Visible?
Yes, it is visible.
Okay, so thank you. So we'll be talking about albumin and fluids in liver disease. Although it is a very big topic because albumin is the only subset of patients where albumin has got some evidence or some good evidence is liver disease. So we'll be dividing the talk quickly in three parts: albumin in cirrhosis, crystalloids in cirrhosis, and then we'll touch on acute liver failure. I'll move on to albumin in cirrhosis. Here we can see, I'll just sorry. So albumin in cirrhosis, we know the first indication that has been there since decades has been large volume paracentesis. And you can see this old study that was done in 1980s and 90s, and they have studied albumin infusion in patients undergoing large volume paracentesis. Now, the problem here is that large volume was more than 5 liters, and this 5 liters was an arbitrary thing. This definition of 5 liters was arbitrary. But what they really found is that after albumin infusion, it decreases the incidence of paracentesis-induced circulatory dysfunction, which is a very detrimental effect of large volume paracentesis, because this PICD leads to increased incidence of renal impairment, hyponatremia, hepatic encephalopathy, and so on. So albumin has also been compared with other plasma expanders like starches for the same indication, and it has been found that albumin is definitely better. So currently we have got an indication of albumin in large volume paracentesis, where we are advised to infuse 6 to 8 grams of albumin per liter of 20% albumin per liter of ascitic fluid that is removed. Now, after this old study of 80s and 90s, many studies have been done on the same topic. And after this, they did meta-analysis in 2012, looking at all the randomized controlled trials on the same topic. And what they found in these 17 RCTs is that albumin reduced the incidence of hyponatremia, yes, PICD, yes, and as well as the mortality. So that was a good solid evidence to continue with the same indication of albumin in large volume paracentesis. In 2019, however, there was another meta-analysis done with some more randomized controlled trials totaling up to 25. And in this study, they found that albumin reduced PICD and hyponatremia, yes, but it did not reduce AKI and mortality. However, there were many methodological issues in this meta-analysis of 2019, and we won't go into the details of those issues. The gist of all these two slides is that even if albumin does not reduce hard outcomes like mortality or renal impairment, it does reduce the clinically important outcomes like paracentesis-induced circulatory dysfunction and hyponatremia. So we will continue, and we should continue, with albumin infusion during large volume paracentesis. The interesting thing is what about paracentesis which is less than 5 liters? So what about modest volume paracentesis? So this was a recent randomized controlled trial from India by Professor Sarin and his team, and where they found that if we do paracentesis of less than 5 liters in patients of acute on chronic liver failure, that is ACLF, albumin still reduced the incidence of PICD, hepatic encephalopathy, acute kidney injury, hyponatremia, and short-term mortality as well. So I guess this study tells us that ACLF is a special subset that should be differentiated from a routine decompensated cirrhotic patient. And although this was a small study of, I think, roughly 80 patients, but this is a good start. And if we get some more studies on the same topic, maybe we can expand the indication of albumin to modest volume paracentesis in a subset of ACLF as well. Moving to the second indication, which is a very common scenario, that is acute kidney injury. So AKI is very commonly seen in decompensated cirrhosis as well as ACLF, and almost 30 to 40% of them have AKI. Initially, when we used to discuss about AKI in cirrhosis, it was called hepatorenal syndrome type 1, type 2, and so on. And for diagnosing hepatorenal syndrome, the first prerogative was that it is related to hypovolemia. So half of the cases were hypovolemic. So it was always advised to stop the laxatives, stop the diuretics, and infuse albumin 1 gram per kg per day for 2 days, and then look at the creatinine response. And if there is a response to the response of creatinine has failed, the creatinine doesn't come down, then it suggests that the patient may have a hepatorenal syndrome type 1. Of course, we need to rule out all other things like nephrotoxic drugs and presence of proteinuria, hematuria, and structurally abnormal kidneys. Now, that was the role of albumin to diagnose hepatorenal syndrome type 1 or HRS-AKI. After that, many studies were done, and it was found that albumin in these scenarios is not just a volume expander. Albumin actually has many other functions like antioxidant effect and anti-inflammatory effect, where it actually binds to the bacterial products and it reduces the levels of pro-inflammatory cytokines. And that was an additional factor which was clinically important because albumin has been compared with other plasma expanders and starches in this same indication of hepatorenal syndrome, along with terlipressin. And it has been found that only albumin improves the outcomes and not just any other plasma expander. Another indication of albumin in hepatorenal syndrome is the treatment part. Now, once we have diagnosed that this patient has got HRS-AKI, the second part says that albumin should be continued at a dose of 1 gram per kg on day 1, followed by 40 to 50 gram per day. And this has to be continued till the duration of therapy. So till the hepatorenal syndrome is reversed, we need to continue albumin of 40 to 50 grams per day. And this was recently studied in the CONFIRM trial that was published in NEJM. And although this trial showed that terlipressin plus albumin is superior to the other arms, the most important point here that we need to remember is that there was a very high increased incidence of respiratory failure in patients who received terlipressin plus albumin. So it was some 15% incidence versus 5% in the terlipressin arm plus albumin arm versus the other arms. So whenever we use 20% albumin or 25% albumin along with terlipressin, we need to also think about the cardiovascular effects and the increased incidence of respiratory failure. So the fluid monitoring at this stage is very important, and we can use the help of lung ultrasound, we can use the help of POCUS here whenever we start treatment of hepatorenal syndrome with albumin. Coming to the third common indication is infections. So spontaneous bacterial peritonitis, a very well-known complication of decompensated cirrhosis. And whenever we have a patient of SBP, since 1990s, it is known that albumin helps after this trial by SORT and the team. So albumin is to be given at a dose of 1.5 grams per kilo on day 1, followed by 1 gram per kg on day 3. Now, although this trial has shown a reduced risk of AKI and mortality, and many other studies after this trial have shown the same results, the dose is still arbitrary. The dose is still not rigorously studied, and different doses have not been compared. However, we still continue to follow the same dose that was used in the first trial that was done in 1999. Now, in this trial and many other studies, the same concept arises that albumin, apart from being a plasma expander, it also has an anti-inflammatory effect and antioxidant effect. So should we use albumin in other infections as well? What about extraperitoneal infections like cirrhosis with pneumonia, cirrhosis with urosepsis, and cirrhosis with skin and soft tissue infections? And many trials have been done. I guess around 5, 6, or up to 10 randomized trials have been done. And recently a meta-analysis of all those trials was published in 2019. And even that meta-analysis could not provide any evidence of improvement in AKI or mortality in patients with extraperitoneal infections. There is no solid rationale why albumin works in SBP and it does not work in other infections. Maybe there are other mechanisms apart from simple anti-inflammatory and antioxidant effects. And there is also a window here that maybe albumin might work in extraperitoneal infections in a subset of ACLF patients, even if it doesn't work in decompensated cirrhotic patients. It's just like albumin to be used in modest volume paracentesis in ACLF. Similarly, maybe we can use albumin for extraperitoneal infections in ACLF, but that has not been proven yet. It is still a hypothesis. Now, coming to albumin itself, the albumin that we measure usually is total albumin, and that is the total albumin that is corrected with our infusions, and our targets are set and our trials are conducted based on this albumin level. However, what actually happens in liver cirrhosis is that the albumin concentration goes down quantitatively as well as qualitatively. So the structure and the function both changes, and what is left is the effective albumin concentration to be measured. So effective albumin concentration in essence is the concentration of structurally and functionally normal albumin. So that albumin which is actually effective for all the effects that we are talking about, antioxidant, anti-inflammatory, and plasma expansion, and so on and so forth. So what we need to measure is the effective albumin concentration, and that is a better marker for prognosis. And I would like to bring to notice this, even though if it's an observational study, it was a really good study done by Maurizio Baldassar in 2021, and they have done a very sophisticated study where they calculated the concentration of native albumin first in patients with decompensated cirrhosis, and that was done by liquid chromatography and mass spectroscopy. And then they calculated the total albumin by a bromocresol green method, and they used a formula from which the effective albumin concentration was calculated. And they followed these patients, and it was observed that the effective albumin concentration is a better marker for prognosis. So I guess in future, if we could devise methods to calculate or to measure effective albumin concentration and then use that levels in our trials and in our studies, then we may get a better answer to albumin dosage and albumin targets. But however, it is still under research, and we don't know the target effective albumin concentration that we need to go for. Coming to albumin dialysis, that is MARS in ACLF. So liver support devices have been studied extensively for many years in ACLF. MARS has been the most studied one. And what it basically tells us that, yes, it improves some parameters and it does not improve mortality. That is what we have been studying since so many years. Recently, this meta-analysis of all the individual patient data was done. So of all the multiple studies, individual trials that were done, including the canonic study that was done on Mars, what they found that yes, Mars improves creatinine and bilirubin levels, it improves hepatic encephalopathy, and it does not have effect on survival. Now, although this was already known, what new this study tells us is that it was focused on treatment intensity. And what they found here is that if you give a high intensity therapy that is more than 4 sessions, so if a patient receives 5 sessions of MARS, that is albumin dialysis, or more than 5 sessions, then it has translated into improved mortality overall in acute and chronic liver failure. So that was the focus of this meta-analysis of IPTMA. And if you are employing MARS in your setup, if you're going for albumin dialysis in your patients, I would suggest, based on this data, to go for at least 5 sessions if you want to see any change in mortality. Otherwise, yes, hepatic encephalopathy and the biochemical parameters would improve even with the lower intensity therapy. That was about albumin in cirrhosis. Coming to the crystalloids in cirrhosis. And to talk about crystalloids, we need to have a look at the circulatory status first. What happens in cirrhosis is that we are dealing with two different systems. One is the central blood volume and one is the splanchnic blood volume, and both of them go in opposite directions. So physiological experiments have shown us that the central blood volume expansion after a fluid bolus is similar in non-cirrhotics and the CPA cirrhotics. So the first early stages of cirrhosis and non-cirrhotics behave similarly. And even if we give the same amount of fluid bolus to patients with a Child-Pugh B or Child-Pugh C class, there is no significant increase in the central blood volume. And keeping that in mind, we see exactly opposite trends in the expansion of the non-central blood volume, that is the splanchnic blood volume. So when we give a fluid bolus to non-cirrhotic or a CPA class patient, the non-central blood volume will not increase significantly. However, the same fluid bolus will cause a significant increase in the splanchnic blood volume of patients with falling under CPB and CPC category. So, and the same findings have been studied for crystalloids as well as for albumin. So crystalloids and albumin are not different in the expansion of the central and non-central blood volume when it comes to decompensated cirrhosis. So what it tells us is that if you have a patient falling in the CPA class, that patient will behave more or less likely just like the non-cirrhotic patient. However, if you have got a patient who falls under the CPB or CPC category, then more fluids are going to cause more increase in the portal pressure, increased ascites, increased peripheral edema, and increased complications of decompensated cirrhosis. So that is the most important point we need to keep in mind. And keeping that in mind, a very, very common scenario that we find in our practice is cirrhosis with sepsis or septic shock. And it is common, tricky. We don't have a solid evidence yet regarding how to go about the fluid resuscitation or monitoring. It is always a constellation of different monitoring parameters from clinical, biochemical, and hemodynamic devices. And initially, of course, we need to give a fluid bolus of 500 ml of balanced crystalloids, or even you can go for 250 ml of 4 to 5% albumin, and maybe you can repeat it once. And I don't think there is any point of repeating more and more boluses, because like we have seen in the previous slide, that more fluid bolus will lead to more portal pressure. It will increase the chance of esophageal variceal bleeding or ascites formation and so on. So I guess a 1 or 2 initial fluid boluses will give us adequate information about the response to the bolus. We start hemodynamic monitoring with echo and cardiac output monitoring and other devices that we have at our disposal. And when the patient enters the optimization or stabilization phase, that is the second and third phase, I guess then yes, albumin has a role, and a maintenance albumin of 40 to 60 grams of 20% albumin per day can be used, although there is no solid backing for this recommendation. So this was a multidisciplinary perspective put by multiple experts all over the world in 2016, and they have advised us to avoid running maintenance fluids if possible, use early vasopressors because there is a low systemic vascular resistance, and use albumin in the optimization or stabilization phase. Only in the initial resuscitation phase, we can definitely go for balanced crystalloids, and there is no hardcore evidence to back NS or balanced crystalloid, but the general consensus is to use balanced crystalloid, and there is no point of deviating from that. Coming to two recent randomized controlled trials, again from India, I would like to tell the FRISK study and the ALBS trial. Both were used in cirrhosis patients presenting to us with septic shock. And the FRISK trial, they compared 5% human albumin and normal saline. And these were small studies of a few hundred patients, and they have found that shock reversal, lactate clearance, and the resolution of tachycardia, so the markers that we usually see at the bedside, they were better in the albumin arm. And the survival day at day 7, that is a very short-term survival, was also better in the albumin arm. Similarly, in the ALBS trial, they compared 20% albumin to plasma light, that is the balanced crystalloid versus albumin. And even here, they found that shock reversal, lactate clearance was better in the albumin arm. The incidence of AKI was also lower in albumin. However, there was no mortality difference in any of the arm. A very important point here, which is a replication of the same side effect that we found in the confirmed trial, is that the pulmonary complications were significantly more in the 20% albumin group. So again, to reiterate the same point, whenever we are using 20% albumin in our patients with decompensated cirrhosis, please look at the respiratory failure. Please monitor your fluid status, use lung ultrasound, use POCUS, use the input-output charting, and try to identify respiratory failure at the earliest. A last point about acute liver failure, is it really different when it comes to fluids? So when we have acute liver failure, it's a vasodilatory state, mimics septic shock. It is very difficult to tell whether it is a septic shock or an acute liver failure on day 1. And due to lack of solid evidence, I think there is no good reason to deviate from our routine protocols. Prefer balanced crystalloids or 5% albumin, whichever is at your disposal. There is no obvious harm in the initial normal saline. If you go in the literature, many people have advocated for normal saline in acute liver failure with the aim of maintaining a higher goal of serum sodium. But I guess even if you use a higher goal of serum sodium, the chloride also creeps up. So keep an eye on chloride, because hyperchloremic acidosis is detrimental in acute liver failure. So you can use normal saline, definitely. Let the sodium go up. It will help you in your hepatic encephalopathy management or cerebral edema management, but keep an eye on your chloride levels. Many centers even use hypertonic saline infusions for acute liver failure patients. But even then, we need to keep an eye on chloride, because that is the more important ion when it comes to normal saline. Thank you.
Dr. Kushal, excellent talk. Actually, you kind of covered all the clinical aspects that as ICU physicians, we are really worried about when we are managing any patients with decompensation. So I will just kind of, the important point that you mentioned was that regarding this albumin, especially when we're giving, though they have found to actually improve your renal markers as well as the other markers, including the mortality in the recent 2 trials. But you also talked about the possibility of pulmonary edema. So obviously, I think that is one thing that you kept on reiterating, and that is very important, that we have to look for extravascular lung water or whatever, use the lung ultrasound to make sure that we are not over transfusing them with albumin just because of the enthusiasm that we want to decrease edema. So if I could ask you something regarding this albumin versus crystalloid for edematous patients with ascites. Like a patient comes in with is edematous, CLD patient, ascites, has some ascites, comes in with sepsis. So at what stage, like you mentioned one of the 2016 studies where they were kind of suggested between 500 ml of crystalloid versus albumin. So in your practice, at what stage do you think that, okay, I have given enough crystalloid, I'll just switch? And is the threshold different from somebody who comes in with septic shock without CLD or without a chronic liver disease?
Yeah, so that's a very good question, and I will acknowledge that it's a very tricky question because there is no solid answer for that. But I would tell what I do in my practice is that when I get a patient of CLD with septic shock, if it's an obvious shock and hypotension, definitely I go along with balanced crystalloids, at least a 500 ml of bolus in the initial 1 hour, and I look at the response to that balanced crystalloid bolus, because if my 500 ml of fluid has caused any improvement in any of the parameters, maybe hemodynamic parameters, or if it has caused worsening in any of the parameters like respiratory oxygenation or something like that, then I guess there is no point of going beyond 2 initial boluses, because if I give a 500 to maximum 1 liter of balanced crystalloid and my patient has not shown much response, then there is no point of giving a third bolus. I would straight away start a vasopressor and then probably think of using albumin there itself. Yeah.
When you're giving the fluid bolus, maybe this is not directly related to fluids, but how do you assess adequacy of perfusion in your patients? Because at the end of the day, you want to normalize perfusion, right? That is why you're giving the fluids and vasopressors. But in liver patients, the lactates might not be clearing as quickly.
Yeah.
They might be having some ascites, so maybe the passive leg raise or whatever might not be that valid. So how do you actually assess the adequacy of perfusion in these patients when you're giving the fluids or vasopressors or albumin?
Yeah. So again, all the dynamic fluid parameters that we see in patients with septic shock, none of them have been strongly validated in cirrhotic patients. So all of them don't hold true, like passive leg raise and PPV and SVV and everything. And even on day one, your patient is mostly spontaneously breathing. So so many of the parameters are ruled out again. So what I do in my practice is, we can't even look at lactate because we don't know if the lactate is because of the liver failure or because of shock. But 2 things, yes, I would mention. One, which is very useful at the bedside, is still CRT, capillary refill time. That is still a good parameter, especially in the upper limbs, even because the lower limbs are usually edematous and it is very difficult to look for CRT in an edematous patient. So I would go for CRT in the upper limbs or at any other bony prominence like the sternum or something. And the second thing that I would look is, although it takes time, the second thing is the trends in lactate. So even if it is because of liver failure or shock, at least the trend will tell me that the patient is improving or not improving. The absolute number of lactate will not tell me much, but the trend will definitely give me some information whether I'm going in the right direction or not.
Right. There are a couple of questions from the audience. So I think there's a question from Dr. Mohan. So he's asking, are there any studies on the use of terlipressin alone to prevent paracentesis-induced circulatory dysfunction?
Okay, so I'm not very sure, because maybe there must be studies done in olden times, because the problem with paracentesis induced circulatory dysfunction is that if you go in the mechanism, when we do paracentesis, the current hypothesis or the current mechanism says that it increases the cardiac output transiently. It causes an decrease in the systemic vascular resistance because of shear stress, and it decreases the effective circulating volume, and that leads to renal impairment, hyponatremia, hepatic encephalopathy, and so on. So this is related to the vascular tone and effective circulating volume. So here, that is why albumin was preferred first. Definitely terlipressin may help, but like we have seen, that terlipressin mostly is used to increase the splanchnic and the portal circulation tone. Although it increases the systemic tone as well, but I'm not very sure if it has been used alone to prevent paracentesis-induced circulatory dysfunction now.
Right. So the second question was regarding HRS. So he's asking if the current update on the definition of HRS has reduced the time required to see the improvement in creatinine or urine output to 24 hours after adequate volume resuscitation. So terlipressin and albumin, are they recommended after a diagnosis of HRS AKI?
Yes, they are still recommended after diagnosis of HRS-AKI. Even if you have diagnosed it early, even if the time to diagnose it has been reduced, and you have definitely ruled out all the nephrotoxic agents and ruled out renal disease and ruled out hypovolemia, and you have given adequate albumin and you have achieved euvolemia, and your creatinine has not come down, and you label someone as HRS-AKI, it is now still recommended to continue with albumin and terlipressin both for the treatment of AKI, and the albumin has to be continued till you see a change in the creatinine levels.
Yeah, I think at the end of the
There's no specific duration. It's not a 5-day thing or a 8-day thing or a 10-day thing, because I've seen in many centers that they stop the albumin terlipressin combination after 3 days or 5 days if it doesn't work. But it's not that. The patient may take a week or maybe 2 weeks to recover from HRS. So you need to continue albumin till then.
Yeah, I think at the end of the day, you're trying to reverse the pathophysiology, right? So
Yes.
for reversing the pathophysiology, you need to do whatever you need to do.
Yeah, absolutely.
Dr. Tapesh, sir, if you have any questions or if anybody else has any other questions.
Just a couple of things. First of all, there was this paper which said the use of albumin in liver disease, in cirrhosis and liver disease. It was a consensus statement by international experts. And there was Professor Shalimar also from our own All India Institute of Medical Sciences, who's a hepatologist. And in addition to what Dr. Kalvit has covered very nicely, a couple of more indications they have given for albumin use. One is, you talked about some sepsis, I think infections, extraperitoneal infections in the setting of chronic liver disease. So they have given one indication, which is evidence-based sepsis in ACLF. So if you're getting sepsis in ACLF, albumin is supposed to be helpful. Second is hepatic encephalopathy. So if you're having hepatic encephalopathy, then again albumin helps. And again, it decreases the incidence of severe hyponatremia. Because actually, what does albumin do? One has to understand why it is helpful in PICD and everything. It fills up the intravascular volume, which is kind of depleted, right? Intravascular volume is effectively decreased in all these patients. So by giving albumin, you fill up this, and you improve the renal perfusion, and you improve the hemodynamics. That is the primary role of albumin. And you covered very nicely about effective albumin. So the kind of albumin that you are circulating is bound to bilirubin and other toxins, a lot of it. And that is actually inflammatory. And you said effective albumin, that is the free albumin, which is the healthy albumin. And when you give albumin, that is actually healthy albumin. That increases the total amount of healthy albumin. So albumin definitely has a role, and you showed the trial from ILBS by Dr. Raki Maiwal and others. They, in the FRIS study, they found a definite benefit in sepsis and cirrhosis. And in that, they had used 5% albumin. But later on in the ALBS study, they gave 20% albumin, which is hyperoncotic, that led to respiratory complications. And that did not result in the same kind of results. So one has to be careful with what kind of albumin also you are using and how fast you are giving it. 5% albumin and 20% albumin, if you give the same amount of albumin over the same time, it is more or less the same. That was shown by Dr. Han. That is what he showed, right? So that makes sense, right? This is the albumin. How, not the, the rate at which you're giving the total albumin, that matters, not the 5% or 20%. Obviously, if you're giving 20% over 5 minutes and 5% over 5 minutes, 20% is going to cause problems.
Yeah.
Right. So that is to be understood. And I think other than that, Dr. Mohan has asked about any studies on the use of terlipressin.
So that has already been answered, sir.
Okay.
So already been answered. So if I could just wrap it up by a small question regarding, because we talked a lot about albumin, not so much about fluids. So what is your choice of crystalloid, like ringer's lactate versus plasmolite in chronic liver disease? You talked about dextrose normal saline or normal saline in ALF, which we were using when we were back residents because we wanted higher sodium for whatever benefit it might give us. But in terms of CLD, ringer's lactate versus plasmolite, do you have a preference or you're okay with either?
No, I'm okay with either. Most of my patients get ringer's lactate. Plasmolite is still an expensive medicine in the Indian population, and of course, if my patient can afford it, I'll go for plasmolite because of many theoretical differences in RL and plasmolite. I don't see any strong difference as far as clinical outcomes are concerned between plasmolite and ringer's lactate. And also in this forum, everyone knows, but I would still like to emphasize for people who are new to this field is that please don't be afraid of the lactate in ringer's lactate, and you can use ringer's lactate in for the resuscitation of patients. Definitely, resuscitation is more important than thinking about the lactate in ringer's lactate. Okay, yeah.
Yeah, and besides, we do not really drown them in fluids anyway. So it's not like if you're giving 3-4 liters of fluid or more than
Yes.
that, then it is not really going to make much of an issue.
So like the organizers have really very wonderfully said in the flyer itself, is that albumin is a friend in all stages of liver disease. So that's a very good line. Thank you for that. Yeah.
Should we move to the next speaker, sir?
Question, Dr. Rajeev.
Yeah. So thank you, Dr. Kushal.
Thank you so much.
There's one more question. Are current albumin dosing guidelines in CLD, ACLF justified for the Indian population? Do we often go beyond 20 grams per day?
Yes, many gastroenterologists, many hepatologists do go beyond 20 grams per day. I've seen many hepatologists go for 20% albumin twice a day, or even infusions of 20% albumin. I don't think there are any specific studies for Indian population, but like on the dosing and the Indian population body structure or body composition. But like I said, that the body structure and composition are not more important. What is more important is the effective albumin concentration. So if in near future we get to a method to calculate or to measure the effective albumin concentration, then we can target that even in the Indian population, irrespective of the body stature or body structure.
I think somebody has also asked about post-paracentesis ascitic fluid protein value. Can it be used to decide about the albumin volume? I'm not too sure about that.
I'm not too sure about that. No.
Yeah. So it will tell you whether it's a transudate or exudate, but I'm not sure it's going to decide about how much albumin you need to.
No, I don't think you can decide anything about the albumin volume on the ascitic fluid protein value. This is not very clear. Yeah. So this
will tell you about transudate and exudate. And all.
Just stretching it too far. You have to give albumin as per the guidelines.
Right, sir. So thank you again, Dr. Kushal.